This is Jim Landman in Kaufman Hall's Thought Leadership Group. Welcome to today's webinar on Healthcare Performance Improvement Insights. Just a few reminders before we get started. First, you can submit a question at any time using the Q&A function on the webinar platform. We'll try to answer as many questions as possible within the hour we have scheduled for today's webinar. Second, we are recording this webinar and will send a link to the recording to all who registered within the next day or so. Today's webinar builds on the findings of our annual State of Healthcare Performance Improvement Report, which we published earlier this fall and is available as a handout you can download from the webinar platform. The webinar will be moderated by Lance Robinson, a Managing Director and leader of our Performance Improvement practice. And with that, I'll turn the webinar over to Lance.
Thanks, Jim, and want to welcome everyone to today's webinar. We had a terrific response to our survey this year. We'd like to thank everyone that participated in the survey. We actually interviewed 8 of our survey respondents and want to give a special thank you to them. Not surprising, workforce-related issues continue to be a major theme for this year's report, but there was some good news here. Almost 2/3 of our respondents noted that the use of contract labor is down and declining in their organizations, which is important because obviously this is the biggest expense from a labor perspective. There were also some signs that financial performance is stabilizing, but at significantly lower levels than in pre-pandemic years. Most of the folks that we interviewed are again seeing positive margins anywhere from in the 1% to 2% range, but it's still a far cry from the 3% to 4% range that we typically see from a long-term sustainability perspective. The fact that 1/3 of our respondents thought that their organizations may face challenges with debt covenants in the coming years indicates that we're not out of the woods yet. So the survey results showed several other significant issues that you see on the slide here in front of you. First, claim denials remain high, affecting revenue cycle performance. 2, inpatient volumes remain soft as the transition of care delivery to outpatient and other alternative sites of care continues. 3, 70% of our survey respondents report the need to board patients in the ED, or PACU, because of staffing shortages or bed capacity constraints. Almost 2/3 of survey respondents are struggling to meet demand for patient access to their physician enterprise. And last but not least, inflationary pressures in 23 continue to drive up the cost of supplies and other labor expenses. Next slide, please. So joining me today to talk through these issues are several members of our performance improvement and treasury capital markets teams. First, Therese Fitzpatrick. She's an SVP in our performance improvement group and will be addressing workforce challenges. Next, Brian Pazarski, who's one of our specialists on care transitions, will be addressing issues related to length of stay and care management. Third, Cedral Moore, a senior vice president in our revenue cycle practice, will be speaking to the revenue cycle issues that our clients are experiencing. Scott Eber will discuss supply chain issues related to our clients. Bonnie Proul, who is a leader in our physician enterprise group, will be addressing opportunities and issues related to the physician enterprise. And lastly, Robert Yeager will be discussing performance improvement related to the balance sheet. And now I'll turn the webinar over to Therese Fitzpatrick so she can discuss some of the workforce challenges.
Great, thank you, Lance. Next slide, please. So as we all know, workforce shortages, while softening a bit in some markets, continue to drive instability with operating margins. In fact, just this morning, Fitch analysts reported in Modern Healthcare that labor costs remain the top pressure point for our hospitals and health systems, and that operational success in 24 will largely hinge on how hospitals recruit and retain employees. The results of our Kaufman Hall survey also demonstrate continuing issues, though there has been some improvement, as Lance noted, over last year. In 22, 27% of organizations reported an increased use in contract labor, while this year only 4% reported an increase in utilization. And as many of us know in our markets, the rates are softening as well. Next slide. So what we're finding is that hospitals are mitigating shortages through increasing flexibility, whether that be increased in utilization of flexible pools, flexible work hours and schedules, or an increase in part-time labor. Next slide. And our survey also demonstrated that 90% of our respondents reported raising wage rates, whereas a significant number are considering all sorts of various bonuses and other frequently unused before these times subsidies, whether that be in daycare. We're seeing some interesting results in subsidies for commuting and so forth. So next slide. So this is going to be, as all the data demonstrates, a very pervasive issue for us for the next number of years. We would suggest that every organization needs to think about interventions in each of the categories that you see on this slide. So whether that is individually or working with our state hospital associations around legislative and regional issues. Examples of this might be the work that's happening with licensure compacts for nurses across the country. Looking to enhance the pipeline through creative and relationships with schools. We think about this within the context of outside in and inside out. So once we develop these relationships with colleges and universities and we develop this pipeline, we need to immediately begin with our brand new employees to think about the next step for them within our organizations. That will also help enhance retention as well. We also believe that there needs to be some creative work around model of care, and we'll talk about that in a minute in terms of top of licensure practice. And then consideration for digital and technological enablement. So whether that be the use of robotics or virtual care, all of those models we are beginning to see utilized across our clients. Next slide. So we have often, before this time, taken a very transactional sort of approach to recruitment, retention, and sort of next steps with employees. So we think that this is an opportunity for all organizations to take a look and do a deep evaluation across 5 phases of talent management, being planning, our systems and processes related to recruitment, the deployment of staff, the optimization of our employees, and then transitioning that staff, whether it be in phased retirement or to other positions within our organization. There is significant opportunity, and you'll see in these slides some potential interventions in each of these phases of talent management. Next slide. So an important piece here that we have sort of over the course of the last 10 or 15 years sort of dabbled in this work around redesigning the actual work processes. We really need to take a refreshed look at this. So making sure we have the right people, changing who performs the work, and embracing true top of licensure team models of care. The utilization of job architecture. So let me say a word about this. Many organizations are still using what might be considered rigid job descriptions versus job architecture, which really begins to set the stage for a sort of latticed career projection. So instead of rigid jobs, to be able to actually state in our job descriptions, once you master this set of competencies, here are the next positions that you will be ready for. that is an opportunity for employees to see growth within our organization and for us to keep them within our organization. Obviously, looking at the right processes to make work more efficient, and then making sure that we are providing the right care, looking at a value-based approach to the right care. Next slide. And finally, I think it's important for us to note that our workforce is significantly changing, that we now need to think about all of the processes that I described earlier through the lens of millennials and Zs. So we are seeing some really interesting opportunities around housing markets. We have a number of organizations that we're working with that are looking at repurposing property, bricks and mortars, around some creative housing strategies for employees, looking at advanced analytics in terms of predictive modeling for our next group of employees coming through. Some interesting work around comp and benefit analysis and looking at creative strategies that are much more attractive to a younger workforce. Scaled retirement planning, and various career paths and learning management systems. So let me end there, turn things back to you, Lance.
Thanks, Therese. Really appreciate that. Next, we're going to move to Brian Pozarski, and he's going to lead us through the discussion around care transition. Brian?
Yeah, so we'll go ahead and move to the care transition slide. So good morning, everyone, or good afternoon to several of you. I am Brian Pozarski. I am a nurse by background, and patient throughput length of stay is where I spent the vast majority of my career. If we'll go ahead and move to the next slide. What we did is during the survey, we had looked at the state of healthcare and the surveys, and this is also some data that we've gotten from clients that we've worked with or collaborated with over the last couple years. And we're seeing increases in challenges, and some of the challenges we're seeing are increases in diversion hours, as well as just overall length of stay, or the OE ratio. A couple other big opportunities that we're seeing is observation stays, and then the percentage of patients that are placed in observation or discharged in observation seems to be increasing at many of our clients or many of our colleagues across the country. We're also seeing significant length of stay opportunities as well as in the emergency room. We see lack of ICU beds availability for those higher acuity patients, sometimes because we can't send the ICU patients or downgrade them to either a step down or a med-surg unit. So again, we're still continuing to see significant or large challenges, but again, we're seeing definite changes in the landscape over the last year. If we move to the next slide. So one of the areas that we always want to talk about is overall length of stay and throughput, and some of the challenges that organizations are seeing. I'm kind of waiting for the slide to move. There it goes. So one of the biggest areas that we just talked about just a moment ago was observation, and patients in observation status. They're not inpatients. And as you can see on the left-hand side, observation rates, or the length of stay of observation patients, has remained the same at over 55% of our survey respondents, as well as we're seeing that at 26% of them are seeing increases in length of stay for observation patients. So some of the tactics that we're seeing at organizations that are higher performing are getting the status right at the front door for all the admissions that come in. So whether they're a surgical patient and they're going to be admitted or kept overnight after the procedure, getting that status right at the front door is the best we can. And then, of course, through the emergency room, we're seeing that as well. We're seeing many clients moving towards and many survey respondents moving towards observation patients being placed either in an observation unit and large enough to capture the majority of the patients that are in the facility, or some type of clinical decision unit that is really being connected to the ED, and the ED physicians are running those clinical decision units. Again, hybrids, and we're seeing different looks of that. But the other side of that is is we're seeing patients come in that are in a clinical decision unit, and how long are they staying versus the obs patients. But what we really don't want to see is patients that are placed on a med surg unit to become another inpatient, and their length of stay remains or is as high as an inpatient length of stay would have been. Several clients are implementing what we call observation huddles. Instead of just reviewing the patient once a day to say, okay, they're in observation, and then we look at them maybe at 9 or 10 a.m. and they're still in observation, and then tomorrow we'll look at them again. Really, we're looking at every 4 to 6 hours having a review of that patient to verify should they be admitted, should they be discharged, or do we need further workup? And then also we see opportunities with physician advisors looking at, there's just times when we need to have doctors talking to doctors about why is this patient here? Does this patient need to be moved to another facility or be discharged? Or again, sometimes those challenges are talking doctor to doctor, and Bonnie and I are working through those with clients as well. We're going to go ahead and move on to the next slide. But we also, as we move to the next slide, we want to talk about using data to make decisions and using data to make process change as well. So the next slide up is around organizations, and we're seeing this again and again. I have some clients across the country and some colleagues that are holding anywhere from 40 to 60 patients in their emergency room every day, or again, holding them in their PACU overnight, waiting for beds to be available the next morning. So as you can see here, the lack of staffing or bed capacity requires boarding patients in the ED or PACU. As you can see, 70% of the respondents per the survey said yes. So some of the tactics that we're seeing clients utilize is covering the emergency room with case managers or a social worker during peak admission times. And we have some clients that are 24 hours a day, 7 days a week, because they just have admissions that are occurring at all hours. Float pool nurses to actually be the nurses for the patients in the emergency room that are holding, instead of having ED nurses that are trying to be ED nurses, as well as inpatient nurses for those patients that are boarding. And then we also are seeing organizations actually working to where they have what they have called bedboard rounds in the emergency department, that they're looking at all the patients in the ED. Why is this patient here, and what is the barrier to moving the patient through? Because of those precious ED beds are being taken up by boarders within the facility or within the ED. We're also seeing that in PACU, and of course, no one wants to hear that we want to decrease or reduce the number of surgeries because we can't get the patients out of the PACU for the next patient to come in. So one of the respondents to our survey actually said, if we could solve our financial problems by just solving two issues, our labor costs as well as throughput, and that was one of the survey notes that we had. We're going to move on to the last slide. So the last slide really talks about what we call the 6 pillars of patient throughput. And that slide really, it shows that there are 6 organizations who are leading practice and have minimal opportunity and are really high performers in patient throughput, are making sure that we're getting the patient status right at all portals of entry, that utilization management and documentation is there and completed and accurate, so we can get the right status at the front door. Care coordination and discharge planning does discharge. I went to nursing school well over 35 years ago, and what I found is, does discharge planning start on admission, or does it start the day after? So if a patient comes into the facility on Saturday night at 6 p.m., do we start discharge planning on Monday morning, or do we start it on Saturday night at 6 p.m.? Care progression and multidisciplinary rounds, multidisciplinary collaboration is imperative. And do we have some type of multidisciplinary rounds on the unit? Physician escalation and governance, I spoke about this a moment ago. But again, there are just times we need doctors to talk to doctors about patient throughput and length of stay opportunities. And then last but definitely not least, is using data and technology to drive decisions. Are we using data and technology? Are we using key performance indicators? Are we following through? And is that data driving our decisions or our process changes as we move? And are we nimble enough to make those process changes? So Lance, I'll turn this back over to you for the next.
Thanks, Brian. A lot of challenges clearly in this area as clients try to address the length of stay and the transitions of care across the organizations. Thank you for that. Now we're going to turn it over to Cedral, who's going to speak to us about revenue cycle. Cedral?
Great. Thank you, Lance. Hello, everyone. Cedral Moore, revenue cycle. So as many of you may know, when you think of revenue cycle, it really does integrate with a lot of the areas we're going to talk about today. But when we looked at the survey respondents and really understand as the environment in healthcare has started to change, there are some key challenges in revenue cycle today. One being uncompensated care and bad debt continues to rise. We really began to work with clients as they started to see more and more of this occur with expiring Medicaid waivers. So then you have patients who are no longer covered under Medicare and a higher uninsured population, so your uncompensated care continues to rise. And then looking tied directly to that are the high deductible plans. As many of us may have, even as employees, we have high deductible plans, meaning that I may come in for an inpatient stay and my deductible could be anywhere from $10,000 to $20,000. Even though I'm covered under an insurance plan, my deductible increases my patient liability. So how do I handle that? Although I'm not a self-pay patient, there are ways that I have to work with those patients as a provider to make sure that I'm covering that cost. In addition to that, through some of the pandemic and so a lot of the things that have happened across the pandemic, and as the job growth began to decline, but then began to increase, you still have a lot of self-pay. So you may have patients that are either unemployed, but don't necessarily meet your charity guidelines, or underemployed, where they are still in a job, but do not have healthcare insurance and still do not meet those charity guidelines. Then you have an increase in self-pay. So then you're looking at together challenges from a revenue standpoint, a cash standpoint, uncompensated care, bad debt, and increased high deductible plans. So you're no longer just looking at one bucket, meaning a charity bucket. You're looking at insured patients with high deductibles. How do we handle that from a payment plan? How do we prevent that and going into bad debt, as well as self-pay? How do we address that prior to service? And even with patients with high deductible plans, we are seeing a lot of changes in the payer mix. So we work with a lot of clients that are seeing a decrease in commercial payers, and that is something that's confirmed through our survey. So as in historically, we saw of 70 to 80%, or maybe even 50 to 80% of commercial payers. Now we're seeing that as a decrease from commercial and an increase in managed Medicare and Medicaid payers. And that is also decreasing our conventional Medicare reimbursement. So we'll take a few minutes and talk about that increase in managed Medicare and how does that impact our commercial reimbursement rates and our Medicare rates. Working with a lot of payers, we are seeing that although the managed Medicare and Medicaid contracts may indicate that they would pay 90% of the Medicare allowable, through deductibles and advantage plans, we're seeing that actual reimbursement closer to anywhere from 55 to 70% of the Medicare allowable. So again, as you're seeing that decrease in insurance from normal commercial payers, we're seeing an increase in the managed Medicare and Medicaid payers. That rolls over into a decrease in reimbursement. So as you're looking at those Advantage plans increasing and that decreasing reimbursement, those are other challenges from a revenue cycle standpoint. And as we're really beginning to see and working with those managed Medicare and managed Medicaid payers, we're seeing increase in clinical denials, especially when we're looking at our Medicare Advantage payers. We're working with a lot of clients now and reviewing a lot of their contracts and denial data to understand what is the root cause of some of their decline in revenue. Where is that revenue declining? And through some of our engagements with some of our clients, we're identifying and increasing denials in the clinical area and some of the payers specifically are the Medicare Advantage payers. So what you are seeing, and that's where we tie directly with Brian and what he's seeing in his area, is that it is not just what we would consider traditional type of denials, or DRG change, a technical denial, or necessarily a patient demographic denials. We've put in place a lot of tools to help identify those challenges or those errors prior to billing. But what we're seeing now are a lot of clinical denials where we have to partner with our clinical teams, make sure that we have procedures and multidisciplinary procedures up front and solutions up front to work with our case managers, understand what our denials are, why are we receiving these medical necessity denials, how do we work with our physicians and their documentation and their patient status, not only from the point of admission, but throughout the hospital stay. The other large area that we're seeing in denials, and as the surveyors identified, a 73% increase in denials, is timely filing, and that's a big bucket. So we're really having to dig into that to understand what is timely filing. We are seeing, especially with our Medicare and Medicaid Advantage plans, they're requesting a lot of medical record documentation. And even though we're sending it to them through the portals, they're not receiving it. So we are seeing, having to dig into those to see that some of this is missing information. Some of those timely filing denials are those that relate right back to our clinical denials. And you really have to dig into those timely filing. Why are we missing the timelines? Do we have anything in our EHR that really identifies an alert of how we need to make sure that we're getting our claims in and our appeals in correctly and timely? So these are some of the challenges, but as we start to look at this across the entire spectrum, the other challenge is we have a different patient base. So when you start thinking about the patient base, and as Therese mentioned, your workforce is changing. Not only is your workforce changing, your patient environment is changing as well. So really, what does your patient need? What are some of your patient needs? How are you satisfying your patients? And some of the things you can think about and some of the challenges are patients are moving from place to place. How do I make sure that throughout my revenue cycle that I'm keeping it patient focused? Our care is patient focused, but now we're really having to think of revenue cycle as patient focused. What do my statements look like? How am I am the first point of contact and patient access to the patient. How am I coordinating with care to make sure that the patient feels that they're getting not only the right care, but they are receiving the information that they need in regards to their financial responsibilities, especially as we're looking as an increase in our uncompensated care, bad debts, and patient liability. Okay, next slide. So how do we really pull everything together? And historically, revenue cycle is operated in a vacuum. We see the patient, we register the patient, we code, we capture the charges, we bill. However, we're living in a different environment today to where we really have to pull together a multidisciplinary and collaborative approach with revenue cycle, clinical, financial, and technology. How do we leverage our EHRs to alert us and to help us get bills out correctly, to identify payer requirements to bring down some of our denials? How do we work with our clinical and physicians to make sure that we're proactively understanding what's required and documenting appropriately, putting patients in the right status, and making sure that we're collaborating across the spectrum and making sure that our patients are satisfied and our processes are working. So really looking at that approach and pulling together a project management team. What is the focus? Not working from a widget to a widget and a task to a task, but really stepping back and looking at revenue cycle holistically. Work teams and a resource coordination. Where should our resources be? Historically, everything has moved to the back end and revenue cycle in the business office. However, with our EHRs, and we have, as you notice, everything starts to move to the front end. And as we look at our workforce, as Therese mentioned, it's not just from a clinical standpoint, but from a revenue cycle standpoint. The biggest risk is getting everything incorrect on the front end. So a lot of our revenue rests with our front end staff. Our front end staff are usually the lowest paid within across the revenue cycle, and we're competing with our Chick-fil-A's and a Walmart. We're competing with other vendors, not necessarily just hospitals, but really looking at that resource pool. What's required in that resource pool? Who are our competitors and what types of skill sets are necessary? In addition to that, how do we collaborate with our case management up front? Really stepping back and building out projects and action plans to combat some of these challenges, and redesigning our processes, importing things like your technology, making sure that you have the alerts, working together with your clinical teams. What is your length of stay? What are some of our risks? What are some of our guidelines and our policies and our tools? And then again, as I mentioned, leveraging your EHR, your reports. What are your trends? Identifying those trends by payer. As we mentioned, a lot of our clients are seeing those Medicare Advantage payers really not paying according to contract, but getting reports and understanding which payer, what are the root causes of your denials, what is the why, and then how do we resolve that? And then what are our relationships with our payers and how do we begin to rebuild those? And then really looking at our ongoing accountability and risk mitigation. How are we placing accountability when it comes to denials? Where are we putting our accountability? Is everything moving to the back into the business office? At that point, we really can't resolve any of the issues. Where should our accountability move? How do we really place that accountability as part of our multidisciplinary teams, working on the front end, working with our clinicians, and working with our case managers and nurses across the spectrum. And using the data that we have to really help us pinpoint the root causes, placing that accountability, understanding where our payer risks are, and then using the data from our patient satisfaction surveys to understand where do we need to improve from a revenue cycle standpoint so that we can improve our patient satisfaction. Okay. I'll turn it back over to Lance.
Thanks, Cedral. So insightful and so important that our clients get paid appropriately for all the work that they're doing. The revenue cycle is such an important part of that. So thank you. So now we're going to turn over to Scott to speak about non-labor and supply chain.
Thanks, Lance. There weren't very many earth-shattering pieces of information that came from the survey. Nothing that was terribly surprising. We do think that, during the pandemic, it was great that the spotlight for a year or two was shined on supply chain and the importance of managing our supplies. We're now seeing that some of our clients are having that spotlight turned off. And with that in mind, we're working closely to ensure that supply chain is seen as a strategic entity, that it has a comprehensive plan that is put in place and that is measured, and that its operational imperatives and the operational goals of the supply chain organization really is in sync with those goals of the broader organization. Historically, the supply chain team was focused on things that were only important to them, their inventory levels, their fill rate levels, their forecast accuracy. We want to make sure that those types of metrics and those types of things that we're thinking about is baked into the broader organization. It's really important to ensure that there's a supply chain governance structure in place. Again, we saw more of these created coming out of the pandemic. We want to make sure that that continues and that the supply chain organization is working really closely with physicians, with clinicians, with other operational leaders. This is true to what we had thought for several years before. And again, during the pandemic, we were able to bring these groups together. We need to make sure that this continues. We're still seeing, as we negotiate contracts with our suppliers, the importance of including KPIs, service level agreements, and making sure that there is some metrics that we are going to manage our suppliers on, making sure that we keep them accountable. It's really important to understand where your supplies are sourced, how they are sourced, what percentage of the items that you're buying are sourced domestically versus internationally. How are your suppliers managing their second and third tier suppliers? Do you know who those are? Those are things that are really elementary within the supply chain space when you think of the Walmarts and the Targets and the Amazons of the world. We want to get to a point, again, coming out of this post-pandemic world, to understanding those kinds of things. And then, of course, when we're thinking about our individual sourcing categories and the areas that we're focusing on and the contracts that we're managing, we want to manage those proactively. We want to understand 6 and 9 and 12 months ahead of time when contracts are going to expire and when we need to start thinking about really understanding what's taking place in the market as it pertains to a specific category. And finally, on this page, one of the real challenges that we've seen as we've moved more and more to the outpatient model and to the use of surgery centers and urgent care facilities is really honing in and managing the supplies for those entities in conjunction with how we're managing the supplies for the broader organization and in the acute space as well. It's really important to standardize and look at that holistically. So if we could move to the next page, when you think about these challenges and the disruptions, and I'll highlight the top 3 or 4 that are on these page, they're not surprising. What has disrupted much of supply chain activity are distribution delays. We see that 71% of our respondents are still highlighting distribution delays. Raw product and sourcing availability remains an issue, and I alluded to that in my earlier comments. There's also a reliance on non-domestic suppliers. I was in a meeting just this morning with a distributor who, coming out of the pandemic, recognized this as an issue and is now manufacturing many of their products domestically on their own, whereas previously they had been relying on overseas product. And then finally on this page, there continues to be at some levels inadequate visibility to our supplies, to our supplier performance, etc. So we want to continue to focus on that as well. And as we go to the next page, and this is my final page, we think about those things that we can do to mitigate some of these challenges that I've referenced. So first, we need to continue to be resilient. We need to make sure that the supply chain organization and that the supply chain leader has a seat at the table with the C-suite. We want to make sure that decisions are made. We've touched on this in almost every one of our topics that we've covered here so far, managing and leveraging data and information that is available at our fingertips. We need to ensure that we collaborate with our partners and hold them accountable and make sure that as we prepare for whatever the next emergency is or the next pandemic is, that we're preparing for what that is going to look like and how we're going to make sure that we're covering ourselves going into that next issue that we may have. Something else that we need to continue to do is to diversify our supplier base. I've already talked about the importance of understanding geographic origin of supplies, but we also want to make sure that we aren't only single sourced in certain categories, and we want to make sure that we are not relying on those offshore markets as we have in the past. And I also talked about the importance, and this is really key, to understand your supplier's supply chain and their sub-suppliers so that you could understand when there are issues, how those can be addressed. And finally, The coordination of care is critical. We need to ensure that the supply chain organization plays a role in the overall designing and redesigning of care throughout the organization. That's bringing those physicians into the mix, bringing them into the decision-making process, and getting them to want to be part of the process. And finally, I'll close by saying, again, the importance of standardizing those supplies across the acute and non-acute settings, making sure that we're capitalizing on volume and aggregating spend across the continuum of care, across all of our entities. I'll close there, Lance.
Thank you, Scott. And so important, being the second largest spend on the general ledger, non-labor expenses are important to focus on, and had a lot of impact during the pandemic that we're just now coming out of. So appreciate your insights there. So now we're going to turn it over to Bonnie to talk about physician enterprise. Bonnie?
Lance. Hi, everybody. My name is Bonnie Prue, and I'm one of the Senior Vice Presidents in Physician Enterprise. And I'm going to highlight two topics today: physician alignment and improving access to care. So health systems historically have partnered with physicians, as you all know, to capture volume, to capture patient allegiance, and their downstream revenue. In 2023, the Kaufman Hall Flash Report showed that the median physician subsidies were up now close to $300,000. This creates some great challenges, and the original physician alignment strategy really isn't sustainable in the long run. So we have to rethink through some opportunities to align with our physicians. I like the analogy in driving physician alignment of the stick and the carrot. Employing physicians and having non-compete agreements really keeps them aligned with the stick mentality, but creates a risk of lack of motivation and innovation for those physicians. But if you joint venture with your physicians and create the alignment with the carrot analogy, there's both an upside for you and the physician. So if you ever wanted to drive physician preference in the OR and efficiency, make your physician a financial stakeholder with dividends at risk in your ASC. If you aren't looking to joint venture with your physician, someone else will. My family recently moved to Florida, and if you know anything about Florida, it means solar panels. We have someone knocking on our door at least on a weekly basis trying to sign us up. And private equity's out there trying to do the same thing with your physicians. Across the country, 1/3 of the respondents to the Kaufman Hall survey are already in joint ventures with cardiovascular and orthopedic practices, with up to 50% of other respondents looking to consider joint ventures in other service lines as well. So we know joint ventures are most notable in the ASC world, but you really need to think about them in other specialties where there's really significant ancillary upside. Allergy with its lifelong immunotherapies, ophthalmology, nephrology in the dialysis space with its infusions as well as pain, not just for orthopedics where they're getting injections, but for pain management are all areas of joint venture opportunities. Next slide, please. Next slide, please. Next slide. There we go. There we go. Thank you. Joint ventures can also be done in a three-way capacity with your healthcare system, your physicians, and with private equity. Private equity right now brings two great benefits to health systems. First of all, from an ASC experience, they have layouts, blueprints, and models of how to implement these. So it's not you taking an inefficient or non-streamlined approach in your surgery center and moving it to an ASC space. That type of thinking isn't sustainable. Second benefit right now is that private equity brings capital resources, and everyone knows that healthcare right now, due to tight margins and little cash on hand, needs this resource. So as I stated before, the idea of physician employment really needs to be rethought. The losses suggest that we need to establish new ways to incentivize physicians to capture revenue and steadily reduce those high subsidies I discussed earlier. I'd like to shift to the importance of access and truly moving to create a patient-centric model of care to get patients into your system and keep them in your system. And I'd like to pose a question to start the conversation. If you, your child, or your family member was ill and needed to be seen by a specialty provider, would you give out your healthcare system's main number to call, or would you work back channels to get your family member or child seen? Next slide, please. Healthcare has seen an uptick in the demand for care post-pandemic. Yet all the time we hear our schedules are just full. A new patient visits 2, 3, 6, 9 months away. We have advanced practice providers whose schedules aren't full and could see a patient in 24 to even 72 hours. How patients are scheduled requires a Rubik's Cube to try and understand. From a call center and scheduler who has no medical knowledge trying to interpret where a patient can be placed in this complex matrix, to these incredible decision-making trees, to having to ask providers for permission to schedule a patient with no-show cancellation slots going unused due to lack of structure and process. So I challenge everyone in healthcare to think, how do we get patients in, and how is our system that we've created really patient-centric? Access can really be improved, but it's going to take really tough conversations. First, patients need to be scheduled when they call. Even, I dare to say, offering them an appointment today or tomorrow. And yes, I said today or tomorrow. High-performing healthcare systems do this, and they've found that only 10% of patients really can come in that time frame. So don't panic when you offer everybody the appointment that you need to go out and hire a boatload more providers. The second thing to do is to leverage your entire care team. Advanced practice providers can be an access point and can see new patients, oftentimes in 24 to 48 hours as that first step. Scripting, managing up your care team can make this happen. Advanced practice providers can do intakes, get labs, order imaging, and have the patient all teed up so that that second follow-up visit with a physician is much more efficient. The patient at the end of the day wants the appointment. They don't want to hear, let us get your records, review them, and we'll call you back in an undesignated time to schedule your visit. That patient's going to call somewhere else. So using this type of model, advancing or leveraging your entire care team really can get your patient in, increase your volumes, and increase your patient satisfaction. So do we make it hard for patients to get in for care? I worked with a practice that discovered they had an access problem, and 30% of their GI referrals from their own primary care providers were going to an outside group because the patients couldn't be seen for a minimum of 3 to 4 months. When you dove in, one of the things that you saw was, no, the physicians really didn't have access, that the advanced practice providers had open slots within 24 hours. When you unpeeled the onion a whole layer down, the guided schedule was built so that the patient couldn't even get in to see an advanced practice provider, even if you wanted them to. So simplifying guided schedules, understanding the role of the advanced practice provider in your care team, got those referrals back into their healthcare system. The next tough conversation comes around clinic templates, standardization, and accountability. I would question everyone, could you pull up a provider schedule today and see frozen slots that are unexplained and unaccounted for? How many of your providers are allowed to refuse a patient from being added to a cancellation slot without permission? How many of your organizations monitor metrics around no-show rates and ask providers to see an extra patient to account for this time? Having patients seen in a timely manner and improving your access, again, needs to be patient-centric. Leaders can successfully manage access, but this really means having solid metrics and reporting measures built and in place. Next slide, please. Key metrics help you drive expansion, optimization, and provide insight that your referrals are actually coming in and not being lost to competitors. I challenge everyone to look at access from the multiple different viewpoints that we have here and go back to my original question. So accessing healthcare should be good enough for our family members without exception. So if your answer to my question was, I don't think my access center would work and I would phone a friend, then the second question you need to ask is, what do we have to do differently to make access a priority? Thank you.
Thanks, Bonnie, for those insights. And I'm always blown away by the $300,000 subsidy. That's just amazing and not sustainable at all. So
yes, sir.
Thank you for that. So now we're going to turn it over to Robert, who will close us out on all the formal comments here, and then we'll have some time for some questions and answers. Robert.
Great. Thank you, Lance, and hello, everyone. Thank you for joining us today. So next slide, please. So in our TCM practice, capital access and strategic capital spending remains top of mind of most of our clients. But how do we do that when credit quality is depressed industry-wide? Then that's mainly due to lower operating performance the past couple of years, and over that time, depressed liquidity from poor investment returns. As a result of that, systems have scaled back their capital spend significantly over those past few years. But I guess how organizations can't sit on the sidelines for much longer when it comes to strategic investing. Many are seeing market share erosion as other acute care competitors invest in their service area, or they have for-profit companies that are moving in on profitable ambulatory business lines that are further eroding their operating performance when they're trying to turn that around. Opportunities may be presenting themselves to acquire some long-term desired assets that may be in your service area that you've wanted for a long time. And as they're struggling, they're looking for a lifeline or a partnership. And can we invest in that strategically? So how should systems be viewing investment right now? Many of our clients are reevaluating and reprioritizing investment into projects with the higher rate of return on investment that support their top line growth while their bottom line profitability. They have to figure out ways to return to the pre-COVID levels, or at least to improve their profitability to a level that's sustainable for a lot of these projects. Now, despite, if you do invest in these higher ROI projects, despite the cash spend or the additional leverage that comes along with that, it's likely to be viewed neutral to favorably by rating agencies. That may be contrary to some thought of many of our, CFOs and directors of finance out there, that how can I, be increasing leverage and my rating, come out maybe more favorably? Well, it's strategic investment is looked upon very, very favorably, and you are given a lot of rope to make sure those investments pan out, as opposed to something like replacement capital spend. So those lower ROI projects or large scale replacement capital spending, those should be reevaluated and determined if they can be delayed until financial performance improves, or re-engineered or reimagined for a lower cost. And many of our clients are doing that right now. So the optimal funding strategy. The previous couple of years, it was pretty easy, right? It was historically low cost long-term debt. We have clients that have 1 to low 3% handle on long-term debt. That makes it pretty easy to achieve a hurdle rate of return above that with projects. But now many see these debt markets that we were in today as too expensive relative to where they were just a year or two ago. But supply remains limited, leaving investors hungry for healthcare paper. Therefore, rates remain reasonably attractive at near 30-year averages. It wasn't all that long ago that a 5% cost of capital was considered low cost, and that's about where we are today. So debt markets are still open. Unrestricted cash and investment levels are improving across most balance sheets, especially if you have larger weighted towards equity markets. They're coming off their October 22 lows. And as your days cash on hand levels are improving, it's easing liquidity pressures on credit quality at the same time you're looking to invest. Systems are focusing on evaluating alternative sources of capital more than they were over the past several years. That could be from cataloging real estate to unlock potential monetizations like sale leasebacks, outright sales, moving services to low cost real estate if they're leased, or moving lease space to own space and then trying to get out of those leases. So there's some unlocking there. You can they are evaluating divestiture or joint venturing partnerships of non-core assets. That could be senior living, hospice, lab, behavioral health. There's others that are out there that may be now considered non-core, or at least not part of the refocus of an organization. And can we unlock some capital through partnering with others and letting them run that business? Or getting a payment to be able to take some of that governance and some of that ownership. Fundraising efforts are more focused than ever, especially on large capital projects that are very visible to the community. And then those entities that, have taxing authority are evaluating using it sometimes for the first time, or at least at a level that would be considered significant, and increasing their millage as to support these strategic projects, especially again those that are very visible to the community, and can easily be supported through taxing authority. Next page, please. So even though rates are near the 30-year averages, it still can't be ignored that they are up significantly from a year or two ago, nearly 150%, depending upon what your credit rating is. The two charts below will kind of show the two different components of long-term debt and what your cost of capital will be, but you'll see that, the 30-year MMD, which is our index that we use for fixed rate debt in the public markets, that's increased nearly 170% since the beginning of 22. And at the same time, credit spreads have widened as investors have kind of reevaluated healthcare credit risk. And they've remained stable over the last year or so, but they still are wider to what they were a year or two ago, up about 150%. So you're looking at this increased cost of capital. What does that mean? Really, the projects that may have been viable a year or two ago, they may not be as viable as they are today. So a reevaluation, and we suggest utilizing a rigorous financial planning approach to capital spending can help inform decision making here. Reevaluate all strategic project spend with a system-wide financial plan, not just focus on a particular project, but do financial planning across the entire system, incorporate all of the strategic capital spend that you're looking at, and determine each one of those projects' ROIs. And if they meet targets, to greenlight them. That could be, do they exceed their cost of capital and are accretive to the bottom line? Can we actually afford it without putting the organization at too much risk? You may have been able to afford it a few years ago, but today it may not be as affordable. Do we need to delay that project until we reach a cash flow margin of 7, 8, 9% or whatever the organization needs in order to be viable to finance that project? And finally, as mentioned previously, identify all those sources of capital available to you. Just don't think about your cash, your debt, and your operations as the only way to finance some of these projects. There could be potential sitting in your real estate portfolio, or there could be potential to unlock other capital in other places that can help finance some of the funding gap that you may be seeing in your project spend. That concludes. Lance, I'll turn it back to you for questions.
Thanks, Robert, and thanks to all of our panelists today. As they say, time flies when you're having fun, so we only have about 2 minutes for questions, but please remember that you can post your questions using the Q&A function on the webinar platform, and we promise we will get back to you with answers to your questions if we don't get them answered today. So maybe we have time for just one question, and this question goes to Therese. And the question is, are there metrics other than retention that could track progress on suggested interventions?
Yes, there are a number, and one of the recommendations is that you develop a very robust scorecard that includes not just human resources, but the operating areas as well. So definitely that scorecard needs to look at staff engagement. That is such a critical component of retention as one example of a metric. Certainly using predictive modeling to help guide what those recruitment plans need to look like, and then a variety of metrics by department, by category of labor around recruitment. Year one turnover is another really important metric to look at. And then sort of the next positions. So as I talk about outside in and inside up, developing those succession plans and monitoring performance to them, not just for leaders, as we've often thought about that, but for staff generally. So just a few ideas, Lance.
That's great. Thank you, Teresa. Maybe we have time for one more, and this one goes to Brian. When you work with clients on length of stay performance improvement projects, what kinds of inpatient or observation length of stay reductions are you seeing?
That's a great question. It definitely depends. It depends on where we started and what were the opportunities as we did the assessment. But at clients, some recent clients that we worked with, for about a 900 bed facility, we saw a half a day reduction in length of stay. And then we had another client that was around 400 beds that we showed about a 3/4 of a day reduction, not only in inpatient side, but we also see the opportunity with length of stay for observation patients. So we're seeing observation patients go down sometimes up to 10 to 15 hours on average. So that's a big help when you're looking at throughput and especially boarding those patients in the ED or in a PACU. Thank you, Lance.
Perfect. Okay, thanks, Brian. And with that, I think we'll end our session today. Thanks to everyone for attending, and we'll be talking to you soon, hopefully. Take care.